Okay, are you seeing presenter mode?
Yes, we are.
Okay, great. All right. Thank you everyone for your attention this evening. As previously stated, my name is Andrea Rideout. I work at the IWK Health Center in Halifax in medical genetics, and we service all three maritime provinces, Nova Scotia, New Brunswick, and PEI. Um, this evening, I'll just explain a little bit about what a genetic counselor is and what we do and how we can help. Um, I'm trying to answer some of the questions that were forwarded to me prior to the talk. Who is the best person in the family to offer genetic testing to? What do the test results mean? What are their implications for yourself and family members? Cascade testing or testing other family members once a genetic cause has been identified, and how to access testing in Canada. Genetic counselors are allied healthcare professionals. We all have a master's degree in science, typically in genetic counseling. In Canada, we are nationally certified. If there's anyone joining us from elsewhere, there are national certifications in the US and Europe. The US has more genetic counselors, so they also have state by state licensure, which we do not currently have in Canada. The typical role of a genetic counselor is assessment and education. We help facilitate genetic testing and help patients make informed decisions and understand their test results. We also provide psychosocial support as people are going through this process. So I just thought I would back up because when we're talking about orthopathies or aortic diseases, there's a whole bunch of different terminology that a lot of it is means the same thing. So I thought I'd go over that. So on the left of my screen, there's a picture I borrowed from my colleagues in Ottawa. So this is our heart. This is the start of the aorta. So this is the aortic root that attaches to the heart. Blood leaves the heart and goes through the aorta to the rest of the body. Um, so um, this dotted line separates the chest from the belly. So thoracic or chest aneurysms are the ones that are most likely to be hereditary, whereas abdominal or belly aneurysms are typically related to lifestyle factors. Aneurysms in the chest that can be inherited have multiple different acronyms to describe them. I use orthopathy. I think it's clear, but it may not be. One acronym is HTAD, which stands for Hereditary Thoracic Aortic Disease, or TAD, Thoracic Aortic Aneurysms and Dissections. They all refer to the same thing, aneurysms in the chest that could be inherited. Then when we're talking about the aorta or the blood vessels, there's also a lot of terms that are confusing to many people. So we all have normal measurements for the size of the aorta. Dilatation means that the aorta is measuring larger than normal. Something is called an aneurysm when it is 50% larger than normal or more. And a dissection is when there's a tear in the aorta or a rupture of the blood vessel. Um, Thoracic aneurysms can be isolated, meaning the disease is only in the cardiovascular system, or syndromic. For example, like Marfan syndrome, where there's a recognizable group of features outside of the cardiovascular system, such as a curve in the spine or a difference in the shape of the chest bone and so on. One of the questions I was asked was, who qualifies for genetic testing? Anyone who has a personal history of a dissection should be able to access genetic testing. Um, Unfortunately, we say we have national healthcare in Canada. It's a bit of a misnomer. Healthcare can vary by which province you live in. The 2022 guidelines suggest that anyone who's diagnosed with an aneurysm under the age of 60 qualifies for genetic testing. Some provinces may test people who are older than that. Some may have a very strict guideline. In the Maritimes, we will test people older than 60, but this may vary by the province that you live in. Anyone who has a family member with a known genetic condition, for example, Marfan syndrome or Loeys-Dietz, then their blood relatives should be able to access genetic testing. And then there are other situations where people may look like they have a connective tissue disorder like Marfan, but their aorta and their cardiac imaging is normal. Those people can also be assessed in genetics, but testing may depend on the individual specific situation. Other questions I've received is, who is the best person in the family to test? This is a completely fake family, but as a situation we get all the time. So Jane's uncle Thomas died of an aortic dissection. He was pretty young, and Jane does what every single person does these days and asked Dr. Google about aortic dissections. Dr. Google told her they were inherited, so Jane would like genetic testing. So in Canada, we like to test the best person in the family. So that is someone that has an aortic aneurysm or survived a dissection. In this case, Thomas is deceased. There may be a medical examiner sample available for testing. But if we offer Jane genetic testing and it's normal, this doesn't answer the question as to whether or not Thomas had a hereditary cause for his dissection. So he could have had an inherited cause, and perhaps Jane didn't inherit it, but maybe other family members did. So sometimes testing an unaffected person and giving normal test results means these other people in the family don't think they need screening, and that's in screening for aneurysms, and that's incorrect. This person we've called Jane has passed away rather tragically at a young age. There was no history of aneurysms or dissections, but then when we went on to screen Jane's family members, again, fake family, we found other people with aortic aneurysms, and all of these people qualified for testing, and a genetic cause can be identified in this situation. So if it's the first person in the family, for genetic testing, we want to test the person who has the most severe disease is the general rule of thumb. So the first person in the family to be tested is called a proband in genetics. So a proband typically goes through a rather rigorous assessment of collecting medical history. So for example, do they have any risk factors for aortic aneurysms like smoking, uncontrolled high blood pressure, atherosclerosis, etc.? Is there a family history of individuals that have aneurysms or dissections? Then we go on to discuss genetic testing, what the risks and benefits of testing are, what types of results do you expect, what are the implications of those results, and help support people to make an informed decision that's right for them at that time in their life. Some people find this whole process very anxiety-provoking, so we provide psychosocial support as needed. And once your genetic testing is complete, typically you should either receive a copy of a report or a letter with your test results, and so should your healthcare providers. So in Canada, the gold standard for genetic testing is a blood test. No fasting is required. I think I say that about, I feel like 100 times a day, but it is one of the most common questions I get. There are other possible options for genetic testing. Not all are necessarily available to everyone. If people have had, for example, a bone marrow transplant, we may need to use another tissue source for DNA. Some medical examiner services will say fresh frozen tissue for genetic testing. So there are other options. Dr. Diana Milowitz recently gave an information session on genetic testing, and she presented sort of the level of evidence we have for genes. So currently, the recommended minimum number of genes that someone should be offered if they have an aortic aneurysm or have had a dissection is 11. Typically, more genes are available, but the exact number of genes may vary depending on the province you live in. Some Canadian provinces will do a basic genetic panel, what we say in-house, meaning in province. And then if they're strongly suspicious of a hereditary cause, if that first line of testing is normal, they may order a more broader panel, meaning more genes. So for example, more than 50 genes. So how we do genetic testing, from a blood sample, we isolate our inherited information, which is called DNA. DNA is packaged into larger structures called chromosomes, which come in pairs of 2. Chromosomes are subdivided into smaller pieces of information called genes. Each gene gives our body a specific set of instructions to do something. So for aortic aneurysms, typically these are genes that are involved in the building blocks of the tissue that makes up our blood vessels and our arteries, and in some cases other parts of our body, such as our skin, our bones, or the lens of our eye. Most genes come in pairs of 2. And what we do with genetic testing is we have what we call a reference sample in the lab. So the reference sample tells the lab what that sequence of the gene should look like. You could think of it as a dictionary. So we compare the person being tested, their gene sequence, to what we expect the genes to look like in the lab. If there's some difference between the dictionary, the reference sample, and the person, that's when we have to decide, is that difference the cause of your aortic aneurysm? So there are three types of genetic test results, which is a nice way to say that it can get super complicated sometimes. So the three test results are normal, meaning we looked at the genes, we didn't find an inherited cause for your aneurysm. The second possibility is a result we call likely pathogenic or pathogenic variant. In the 90s, this was formerly called a mutation. Pathogenic variants are known to be disease-causing, meaning that is the explanation for the aortic disease. Unfortunately, there's a third type of result called a variant of unknown clinical significance. That means we found a difference in the gene and we're not sure if it's disease-causing or if it's a normal difference. So for now, I'm just going to focus on the likely pathogenic or pathogenic results. So these are the disease-causing ones. So the reason we have two classifications is based on the level of medical evidence. So if something is classified as likely pathogenic, it means the scientific community as a whole is 90% or greater certain that this gene variant is the cause, in this case, of an aortic aneurysm or dissection. Pathogenic, depending on the lab, may be a benchmark of 95 or 99% certainty. But the good news is this test result gives us the genetic or inherited explanation for the aortic aneurysm. Once we have found the cause in the proband, so that's the first person to be tested, then family members can have genetic testing for that specific variant. So they don't go through the whole panel of genes. They should be just testing for the one thing that we know is in the family. One of the benefits for genetic testing is the specific gene that has the error in it or the specific variant most likely will help your surgeon give information to plan surgeries to repair aneurysms. So for example, some genes are known to cause aortic dissections at a smaller size compared to other genes. So if you have one of these genes where we know there's a risk to have an aortic dissection at a smaller size, then they would take that information and plan to do surgery sooner rather than later. Other things we can get from genetic test results is there risk for aneurysms outside of aorta. Some genes may have a risk for brain aneurysms or aneurysms in other part of the body. Some genes may confer risk for other health problems. So for example, the gene for Marfan syndrome, one of the things we worry about is the lens of the eye can dislocate or slip out of place. It can detach and cause blindness. So if you have an aortic aneurysm due to a variant in the Marfan or the FBN1 gene, we'd recommend eye screening. The genes for Loeys-Dietz often confer a risk for early onset osteoporosis for men and women. So you would need bone density screening, perhaps at a younger age. And ACTA2 doesn't have a syndrome name, but it can also increase your risk for early onset strokes or coronary artery disease. So now that we've identified the inherited cause, we want to know how is this inherited and what are the risks to other family members. So for Loeys-Dietz and Marfan syndrome only, about 25% of the time or a quarter of the time, the first person in the family found to have Marfan or Loeys-Dietz may be the only person in the family with it. Both of these conditions have a known phenomena of having new genetic changes at the time of conception that weren't inherited from mom or dad. Medical term for this is called de novo, which means new. So in this situation, if this person's parents, don't have the gene change, then there's a very low risk to their siblings. However, once the gene change is present in the patient, they can pass it on to their future children. For most of these genes, and for the other 3/4 of people with Marfan and Loeys-Dietz, the pathogenic variant is inherited from an affected parent. So in this picture, we have the parent in red. They have an aortic aneurysm that is the hereditary type. They have one gene that has a normal sequence. they have a second gene with the pathogenic variant causing the aneurysm, we would typically assume the other parent does not have one of these conditions. So for the parent in red, when we go to have children, we pass on half of our genetic information or one of our 2 copies of the gene. So if this first child did not inherit the pathogenic variant, so they did not inherit the disease, in this situation, we would say they don't need any screening for aortic aneurysms because we know they didn't inherit the family variant. And since they did not inherit the variant, they cannot pass it on to their children. So you can't pass on what you don't have. However, for child number 2, they did inherit the pathogenic variant. So we would say that they are at high risk for aneurysms. And that this child can also pass this on to their children. And the risk to pass on the gene or the pathogenic variant is 50-50 with each pregnancy. So if you're a parent, it could be that both of your children inherit it. Neither of your children do, but statistics would say likely one will and one won't in this situation. So with most autosomal dominant conditions like aortopathies, there's a phenomenon we call reduced penetrance. So learning that you've inherited the gene for an aortic aneurysm syndrome or aortopathy, it's no crystal ball actually. So the results cannot tell us for certain if you will develop aortopathy. Simply it tells us that you're at higher risk. We cannot tell from the genetic test results at what age you will develop an aneurysm or at what age you will need surgery. There is variation within families, so some family members may be more severely affected. So for example, maybe one person in the family would have an aortic dissection in their 30s and 40s, but maybe their 80-year-old grandma has the same gene change and is fine and has a stable aortic aneurysm. So there can be variability. And so learning that you have inherited the gene change, we just simply say you're at higher risk, but we can't predict what the future may hold. We just want to make sure that you get access to the appropriate medical screening to catch any problems so we can repair aortic aneurysms before they rupture. In some situations, the difference in whether or not people develop an aneurysm, we've noticed some differences between males or females, but we certainly need more data to confirm that. And if you have inherited the pathogenic variant, even if you don't develop an aortic aneurysm, you can still pass on the gene to your child. So the gene or the pathogenic variant does not skip a generation, but it may appear to do so if that person doesn't have an aneurysm. So if someone does not inherit the pathogenic variant, we would say they can't pass it on to their children and no screening is needed. So cascade testing, another term that we use for this is called predictive genetic testing. So this is speaking to a family member who perhaps either has not had any cardiac imaging or maybe had cardiac imaging and doesn't have an aneurysm. And they know that there is a pathogenic variant for one of the inherited aortopathies in their family. How to access this service in Canada is through referral to a medical genetics clinic or via a genetic counselor working in a cardiology clinic. So cascade testing for adults, we do many of the things I've already discussed. We take family medical history. We usually require the family member's genetic test report. This isn't about obtaining like family secrets or anything like that. We need to make sure that when we offer this person testing, we're testing for the correct variant within the family. There can be lots of complicated numbering systems and ways we name pathogenic variants that can change over time. So the reason why we need the family member's test report is to make sure we're testing you for the right thing. So much of the discussion will focus really on if you have inherited the pathogenic variant, what are the implications for your medical care? What are the implications for your family? Some things that people don't think about, if you've inherited one of these pathogenic variants causing aortopathy, here in the Maritimes, we have a lot of people that work in the trades or as fishermen. So if your only training is to be a lobster fisherman and you found out you have a gene that causes a high risk for aortic aneurysms, all the physical demands of being a lobster fisherman aren't recommended anymore for you. So people may have to retrain to do something else, or in some situations, they don't have those options. So this can be a huge life-changing piece of information to learn about this. As well, maybe other people don't have physically demanding jobs, but maybe a lot of their social life focuses on sports like competitive hockey, marathon running, triathletes. Learning that you have one of these conditions where those activities are not recommended at the level you're used to doing them can have a huge impact. Maybe it changes their entire social circle. So there are other implications aside from family dynamics and medical implications. A lot of it can spill over into parts of your life that you may not have considered. And of course, there is a huge emotional component to learning that you have inherited one of these conditions. Really, you're learning about a new piece of information that's been present since birth. Some people, it changes their self-concept, and they can really struggle. Other families seem to do much better. It's kind of more normalized for them. So that's very individual to the person and their lived experiences. So a lot of people come into clinic and they're embarrassed about their family dynamics or family situation. I can tell you some days I feel like a hairdresser. I feel like I've heard it all after 20 some years in genetics. Everyone's family is unique, but some of the challenges families face in complicated dynamics are not unique. They're actually more common. I just don't think people talk about them often enough. So there are families that are hesitant to share information. Oftentimes, people may not understand the implications of keeping that information from other family members. There may be fear of exposing family secrets. So, for example, in the Maritimes, not that long ago, it was very common if a teenage girl was pregnant, another family member would adopt the child, and that baby could be raised as their sister or cousin or what have you, and they were never told. And then, of course, when genetic testing comes in and trying to sort out family relationships, people fear exposing these secrets. Some people feel very guilty about passing it on, and they feel that they cannot emotionally handle learning that information. And often everyone wants to protect their children and their family members from harm, and they feel like by not telling them this information, they're preventing emotional harm. But information like this really saves lives through screening and surgery, because aortic aneurysms typically don't have any signs or symptoms until they dissect, in which case they're life-threatening. Others have concerns of discrimination, which I'll address in a later slide. But every family situation is unique. I can say in 20 years, there's usually always one family member that doesn't want to know, and maybe 10 others that don't understand the rationale. So one thing that's a little bit different with Cascade testing or predictive genetic testing is testing for children. So some families really struggle. Oftentimes, aortopathy can be an adult onset condition. So if you're uncertain about testing your children, you can always go on the path of screening with a heart doctor. And then children can decide about whether or not they want predictive testing once they reach adulthood. This may surprise some people, but we have a pretty firm rule that once children are of the age of 13 years or older, we want them to participate in the discussion. So we're not going through all of the nuts and bolts of genetic testing and medical management, but we do want them to understand it's an inherited condition that may impact their life. So for example, if your child's dream is to be the next Sidney Crosby, well, if they inherit one of these conditions, they may be able to play hockey quite competitively, but the minute they get an aortic aneurysm or changes in their aorta, their cardiologist may say no more hockey, or depending on the family's situation, they may say no hockey from the get-go. So that's just one example. So children need to be aware that this information can have impacts on their lives beyond sort of just regular other kids. And this is really unique. This will depend on your own family's values and beliefs and your parenting style. And there's no right or wrong answer. The right answer is always go back to screening for aneurysms. Um, so when we're talking about testing children that are less than 13 years of age, generally speaking, those decisions are made by the parents. So we want to weigh the risks and benefits of testing a child for an adult onset condition. And again, not all families will the aortopathy be in adulthood. There are some families where teenagers are affected and young children in rare cases. So we want to go back to our ethical principles. So if we're making a decision for our child, when that child is an adult, the decision was already made for them and they weren't part of the decision-making process. Some children, or adult children, I should say, are upset when they learn this. They feel like they wanted to make that decision for themselves. Our basic principle is to do no harm. So sometimes testing children when they're young and finding out they have one of these conditions can lead to things like overprotection or negative impacts on the child's self-esteem. We all know that self-concept and self-esteem is important to be an accessible, functional adult. There's fear of stigma and discrimination. So for any of those of you that haven't grown up in a small town, there are no secrets in small towns. Everything always comes out. So if you test your child for Marfan syndrome and you tell your neighbor, the entire town will know lifelong that your child has Marfan syndrome. And maybe by the time your child's a teenager, they really wish that you hadn't shared that with the neighbor and they feel that their privacy is breached. On the flip side, some children may be glad that their parents made the decision and they've got really good medical care. So everyone is unique, every child is unique, and a lot of thought really needs to go into these decisions about timing for testing. Throughout the years, a lot of people have declined to come to genetics appointments for fear of discrimination. So unfortunately, there wasn't a lot of information about this in the popular press. So in 2017, the federal government passed the Genetic Non-Discrimination Act. So this is under the Canadian Human Rights Act that bans discrimination based on genetic characteristics. So this protects the use of your genetic test results outside of medical care. So a third party, such as an employer or an insurance agency, cannot ask for your genetic test results. It's subject to a fine of up to $1 million. And then this law is specifically designed to protect individuals undergoing predictive genetic testing. So insurance companies are not allowed to ask for your test results. However, if you are going for private insurance policy, insurance companies will collect your medical records. And if your medical records say you have an aortic aneurysm or you had an aortic dissection, they may use your symptoms or your aneurysm to discriminate against you, which is different than your genetic test results. So I've put a link here for more information about that law for anyone that has questions. I am certainly not a lawyer nor an insurance agent. So just to complete walking through our genetic test results, so this does not apply to the situation we just talked about, where we have a pathogenic variant that's causing aortopathy. We're going back to our proband, so the first person in the family that has an aortic aneurysm that had testing, and their test results are normal. So in genetics, we call this an uninformative result. We did not find an inherited explanation for their aortopathy. However, that doesn't mean that they don't have a hereditary cause. We all know that genetic testing is not perfect, and we all know that new genes will be discovered that cause aneurysms. So, erring on the side of caution, if you have an aortic aneurysm and your genetic test results are normal, screening for aneurysms is still recommended for your first-degree relatives. So that's parents, siblings, and children. They should have ongoing screening for aneurysms. And in this situation, because we didn't find an inherited cause for your aortopathy, we don't really have any genetic testing to offer other family members. So if you are in this situation, I suggest you wait a few years and then ask for a re-referral to medical genetics or your cardiologist if they did genetic testing. to see if there's more genes available for testing. And also for families in this situation, you can also ask your healthcare provider about enrolling in research studies that are looking for what we call unsolved families, meaning we think there's a hereditary cause that we can't find, and there are gene discovery projects for that. The third type of test result is the one I think we dread the most in genetics as healthcare providers. So we're gone back to our proband. They've had found to have an aortic aneurysm. They were offered genetic testing for a whole panel of genes, and we found a genetic variant of unknown clinical significance. So the best way I can do to explain this, I stole this slide from a genetic counselor in Alberta. Thank you. If we look at the people in this slide, as you can see, no two people look alike. There are differences in hair color, eye color, skin tone, bone structure. All these are genetic differences. They're just normal variation in the population. So none of the variants for differences in skin color, eye color, etc., are disease causing. So all of our genes are going to be unique to us, just in the way we don't look alike. Neither is the sequence of our genes all identical. So when we see a difference in a gene, the laboratory has classifications of genetic variants, and these classifications are rooted in medical evidence. So on the far left, we have benign and likely benign. So these variants are not disease causing. We are at least 90% certain that it is not disease causing, or 99 at this end of the scale. These variants don't make it into a genetic test report because they're essentially normal. Then on the opposite end, when we found an explanation for an aortic aneurysm, we've reached at least a 90% level of evidence here. So we knew these variants are disease causing. Anything in the middle, we don't have enough medical evidence to be certain if the variant is disease causing. That could be because maybe you're the only person in the world known to have the variants. It could be there's been reports of people with variants with the same genetic disease, or reports of people with a different condition with the same variant, and the data is conflicting. So I put this variant of unknown clinical significance into this program just to show you the scale. This is actually the gene for Marfan syndrome. So this would be the middle ground, meaning we don't know if this VUS is disease-causing or normal variant. This one, though, is looking promising towards going towards disease-causing, but we're not quite at that level of evidence we need. So this is one where we suggest people that have these variants of unknown clinical significance check back in 2 to 5 years to see if there's more information. Most of the time, because genetic testing is more widely available worldwide, we get more information quicker than we used to. So one of the reasons we don't use variants of unknown clinical significance to test other family members is because we don't have enough medical evidence. We're concerned that testing other family members for this variant may cause more harm. So for example, what if we test your brother or your sister and they say, oh, they don't have this variant of unknown significance, we're not letting them have aortic screening anymore. And that's not what we want to happen. If we're not certain, we want everyone in the family to continue with screening. So we're trying to reduce harm. When we find a variant of unknown clinical significance, generally there is no predictive testing available. However, if the variant is highly suspicious for disease causing, they may offer it to other family members to see if it's tracking with the family history of aortic aneurysms. That service would only be available through a genetics clinic and would be up to the discretion of the healthcare provider. Okay, so genetic testing in Canada. So there's been some myths. Genetic testing is actually covered by the provincial healthcare system, regardless of which province you live in. Access to testing may be in some provinces only through medical genetics. Other provinces may have specialist aortopathy clinics where they have a genetic counselor embedded into their practice, or Specialist cardiology clinics without genetic counselors can offer testing to probands. So the number of genes tested at minimum should be the same across Canada, but those extra genes, some of them are sort of newer, may vary by province. So not all provinces will pay for genetic testing on a deceased family member. So in Nova Scotia, we have a lovely medical examiner, and in cases of sudden cardiac death, he orders genetic testing and he offers all the families referrals to genetics if they want it and ensures that they get access to cardiac screening. Ontario, I know, will do genetic testing through the medical examiner's office. PEI will here, but New Brunswick does not, and this varies across the country. So I know some of the provinces out west will not pay for genetic testing on a deceased family member. The healthcare system doesn't pay for it, so that is unfortunate. Whether or not your local medical examiner has access to genetic testing, quite often they will save samples. So even if you've had a relative die of an aortic dissection, it's worth contacting the medical examiner or perhaps getting your healthcare provider to see if there's a sample saved for genetic testing. There may be something that we can use. And Canada, it's no secret, we are short on everything in the healthcare system. We are short on family doctors. We are short on nurses. Other things that don't make the news, we are short on administrative staff and booking clerks. So our wait times are increasing, which is really unfortunate. But if you have a family member that has a known aortic our known genetic variant causing aortic aneurysms and dissections, as long as that information gets to the person who's receiving a referral. Typically, you're not going to be put on the routine wait list. The wait time is typically months and not years. So a lot of people in Canada don't have a primary care provider like a nurse practitioner, a family doctor, which can make it very difficult to access genetic services. You can always go through a walk-in clinic or one of the online healthcare services, or my suggestion would be to contact your local genetics clinic and ask if they take self-referrals. So I created this slide a couple years ago. I'm able to get updates from a few provinces, but generally every province you can access genetic testing through referral to medical genetics. I've ticked off a couple of provinces that have some genetic testing available in cardiology clinics. I have a question mark by New Brunswick because New Brunswick has a very complicated health system, and some primary care providers and some specialists seem to be able to access genetic testing on their own in New Brunswick and others do not. And I have not figured out a rhyme or reason to it, so I apologize. In the East Coast, because of the shortage of family doctors, most of the clinics will take a self-referral. And then I have this marked off too for Manitoba. Alberta will take a self-referral from someone who has a family history of a genetic variant, but I'm not certain that they will take a referral from someone who has an aortic aneurysm and no family doctor. Also in Alberta and Ontario, there is access to private genetics clinics, and I'm not aware of those in other provinces. So if you're not sure how to access genetic services, we have a national organization, the Canadian Association of Genetic Counsellors. The website's in English and French. You can go to this website, click on Find a Clinic, and you should be able to locate a genetic service near you. Typically, the best thing to do would be to ask to speak to the genetic counselor on triage, and they should be able to assist you with the best way to get a referral to their clinic or accept a self-referral. Some of the other questions I was asked to talk about are different types of genetic testing. So we talked about what we call a panel testing for the first person in the family to be tested, or a proband. So a panel is a shorter version to say the person is having next generation sequencing to look at multiple genes that cause aortopathy. Once we have identified the specific genetic variant in the family, then genetic testing is for the family members is only for that one variant in most situations and not all the other genes. There are other types of testing which are not widely available across Canada. So in Nova Scotia, we have access to whole exome sequencing. So that looks at all of our genes, coding regions which provide the instructions for growth and development and so on. That test is typically used for children who have intellectual disability, delays in their motor milestones, and other health problems like congenital heart disease or complex medical needs to see if we can find a unifying diagnosis. Um, Whole exome sequencing actually has a very low pickup rate for aortopathy and connective tissue disorders. It's around 15%. For a child with multiple medical problems, it's probably closer to 40 to 50. So panel testing is the current standard of care. The only province I'm aware of that does offer exome testing is through medical genetics clinics in some regions of Ontario, and I don't think that this test is available to every person with orthopathy. I think they might have to have some additional features that we would consider them syndromic, so having disease outside of the cardiovascular system. The other test I was asked about is something called whole genome sequencing. So whole genome looks at all your DNA, whereas the exome only looks at the part that gives our body instructions. We have other bits of genetic information that contains regulatory elements, meaning turning our genes on and off and so on. That is currently more of a research test in Canada that we use for gene discovery. It is not really clinically available in those provinces, although I suspect that will be changing sooner rather than later. Other types of testing are private pay options. One that I wanted to touch on briefly is something called direct-to-consumer testing. So I think all of us have probably seen ads on the internet for 23andMe or other genetic testing companies for things like ancestry or health information. If you can order a genetic test in Canada without a healthcare provider's signature, then the lab that is offering you that test is not accredited for medical testing. So here's an example of an article published in the New York Times. This was based on a real study in the New England Journal of Medicine. So they did a study of Americans. So remember, Americans have to pay for all their health care as soon as they walk in the hospital, whereas we do not in Canada. So people decided to do genetic testing to determine whether or not they needed breast cancer screening. And unfortunately, 40% of the time, the test results from direct-to-consumer testing were incorrect, meaning some women were told they did not have a breast cancer gene mutation and discontinued screening, and were later diagnosed with stage 4 cancer where there's limited treatment options. Other women were told that they had a genetic mutation, increasing their lifetime risk for breast and ovarian cancer. They had their breast and ovaries removed, and the test results were wrong, and the surgeries weren't necessary. So we're talking about the US. There is an article in CBC of a patient from New Brunswick that was seen in our clinic that was frustrated by the wait time, did 23andMe, got normal genetic test results, came to see us and said, I don't need genetic testing. And she eventually went through with clinical testing, and she did actually have a mutation that wasn't picked up, or a pathogenic variant that wasn't picked up by 23andMe. And she was so gobsmacked by how much she was misled by direct-to-consumer testing. She went public. So buyer beware. If you can order testing online without a doctor's signature, it's probably not very accurate. And if anyone does direct-to-consumer testing and is told they have a pathogenic variant, then I suggest they get a referral to a genetics clinic to confirm whether or not that's correct. Oftentimes they are not. The best thing to do is to contact the company directly and ask to speak to their genetic counselor to go through their test results. As you might imagine, as a public service, we have limited resources we can dedicate to what we call this recreational genetic testing. So, and just a plug for MAC that Linda had mentioned earlier. What MAC is doing is collecting your genetic information and your medical information, and it's anonymized. So what we want to know, do the specific pathogenic variants Even if they're all in the same gene, do those variants confer different risks for aortic disease or other features of connective tissue disorders? All that information is collected and reported in a group format, so it's non-identifying. And the information is being used to help give your cardiologist, your genetic folks, and your other care providers information. If we don't know the medical history behind someone with a specific genetic change, then we're stuck in the situation where we don't know what to tell patients who come after you have the same genetic change. So the thought behind MAC is to find out what symptoms you have, what age you had an aortic aneurysm or dissection, and collect this information so we can report it in a group format to see, do we need to change what size we offer people surgery for aortic aneurysm repairs? Are there other health things that we need to look out for specific variants like aneurysms in other locations? So you can help the medical community learn about these conditions and improve the care of other people. So if you're willing to share it, it's really important. It's good work to help other people. And hopefully the goal for most genetic conditions is to use the information for better treatment options, either by medications or possibly even by gene therapy. So this is my dog, Joe. I think Joe's a bit inspiring. He was a rescue who was frankly a money pit, but even with all of his health problems, maybe you're lucky enough to have someone buy you a set of wheels so you can get around. Thank you for your attention. Are there any questions?
Let's see. We don't have any open questions at this point. Let's give it 1 minute to see if anyone has any.
I have the email questions.
Okay.
So I can read one off. Sorry, I'm not looking at the camera.
Okay.
Even though my daughter and my grandson tested negative for the ACTA2 variant, they continue to be seen by cardiology and are imaged annually. Why is this necessary? So my question is the ACTA2 variant classified as pathogenic, meaning disease-causing, or is it a variant of unknown clinical significance? If the variant is unknown clinical significance, then they should probably continue with screening. My other thought would be, is there something else going on in the family history where the cardiologist wants to continue screening? Or has the information about genetic test results, if the variant is pathogenic, has that made it back to the cardiologist? Okay, my second question is, my brother died from an aortic dissection. I have an aortic aneurysm. My sister and I have cerebral aneurysms. The final interpretation from GeneDx reads, this individual is heterozygous for a variant of uncertain clinical significance in the FBN1 gene. So the FBN1 gene causes Marfan syndrome. So Marfan syndrome typically isn't associated with cerebral aneurysms. And a variant of unknown clinical significance means we don't have enough information about that specific gene change to know if it's the cause of the aortic aneurysm. So I would have questions like, how long ago was this testing done? If the report is more than 2 years old, I would ask my healthcare provider to contact GeneDx to see if there's any new updates to that FBN1 variant. Or I would also want to know what other genes were you tested for, because there are other genes that are definitely known to cause aortic and brain aneurysms or cerebral aneurysms. So it could be that FBN1 variant may not be the answer. There might be some other genetic cause that hasn't been identified by the test method used. Hopefully that answers your question.
Andrea, we do have a question that's come in through Q&A.
Okay.
I'll read it to you. So if I am understanding correctly, I have a gene variant in MYH11, but it is unknown significance. So at this time, getting my children genetically screened isn't necessary? Question. Both of my children have gotten an echo and they did not recommend any further follow-up. Okay.
So if you have a genetic variant of unknown clinical significance, we're not sure if it's the cause. I'm assuming you have an aneurysm. So in that situation, if you have an aneurysm, we recommend ongoing screening for your children, brothers, sisters, and parents. If your children are very young, maybe they're not recommending further screening to adulthood. They definitely should have ongoing screening until the MYH1 variant is clarified to be disease causing or not. If it is disease causing, then they can have predictive testing. If it's still classified as a variant of unknown significance, then your children and other first degree family members should continue with screening.
Okay, that's great. Thank you.
Yep. You may want to touch base with the people who did genetic testing for you to clarify that that is still the current recommendations based on the variant.
Okay, one more question here. What is the
Mhm.
approach for reanalysis of genetic variants? How frequently does this process occur? Is it the individual's responsibility alone to ask for reanalysis?
Great question. Yes, it is the patient's responsibility alone to ask for reanalysis. Genetic variants of unknown significance are really common. We see them, I'm not just talking about aortopathy, but all genetic assessments, probably in 1 in 20 people. And we, as healthcare providers, we can't go back and reassess every single variant. So we always, or most clinics will tell the patient to contact us in 2 to 5 years. If you contact us at that point, we can have another look at your variants. Or if you had normal genetic test results and you want a reanalysis, like are there more genes available? Is there better testing technology? That's the time to reach out to the healthcare provider who did your genetic testing and find out is there more testing available, or would there be reanalysis available to you, and what is the process to access that?
Mm-hmm. Okay.
Mm-hmm.
I think we've answered the second. Yeah, I think we've answered those two
Okay.
questions there.
All right. So the third question I had by email was, how many genetic mutations are identified each year related to dissections? Is there a system in place to compare these findings to existing databases among other facilities? For instance, my genetic test results are at Johns Hopkins. Does Hopkins share? I don't I don't actually know right off the top of my head if Hopkins share. Um, so there are publicly available databases of genetic variants, all commercial laboratories. So someone had mentioned GeneDx in an email. That's a US lab. In Canada, a lot of us use Prevention Genetics or Blueprint. Those laboratories actually put their data into these publicly available databases so other people can have access to it. However, if you had testing through a hospital lab in Canada, not all of those labs are sharing their information with the international databases. If I had to guess, the reason for that for most laboratories is basically a staffing issue. They don't have time. It's not for lack of desire to share their information. So I'm not sure how many genetic mutations or variants are identified each year related to variants. In theory, I think if the person has had a dissection and there's no family history, the chance should be around 10% in that situation to identify a genetic cause. So if I knew the number of dissections per year, I could probably do the math for that one. All right. Would genetic testing in Europe versus North America bring different results? So all of the information I shared with you about our knowledge of genes causing orthopathy is available worldwide, and most countries will offer a similar genetic test panel to what I went through for proband testing. So, like I said, a minimum of 11 genes, although most labs test for anywhere from 30 to 50. So what access you have and how many genes tested may depend on where you live. But in terms of the actual genes available for testing, that information is known worldwide. It's just a matter of how to access it from your home country or home
Mm-hmm.
province. Hopefully
Mm-hmm.
that makes sense.
Yeah.
So if you had genetic testing in North America and you moved to Europe, the only thing I would check is to make sure that what is available to the country you move to, is it the same test method and were the same genes tested, and is there something different or new available where you move to?
Yeah, that's great. Thank you so much. I'm just checking to see if we have any other questions before we close out. I don't see any others coming through.
Okay.
Well, yeah, it's been like really lovely to speak with you this evening. I know that
Thank
a
you.
lot of the questions we receive at GATA are questions about genetic testing, and the
Mhm.
science is advancing at such a fast rate
Yeah.
that the layperson's knowledge is just so far beyond the information that's out there, and it's really important and informative to have been able to speak with you tonight. And I encourage anyone who's listening, if you have other questions or questions come up that you felt weren't answered or you'd like some guidance, we will do our best if you contact us to connect
Mhm.
you with the right resources. And Dr. Diana Milovitz, at her webinar that she presented recently, she invited people to contact her directly, or you can reach out through GATA if you'd like to participate or find out more about how to get involved in the work that she's leading through MAP or through Gene Discovery Program. We're happy to answer as many questions as we can about that or refer people to the resources that they need. I think that's a big part of this topic is
Mhm.
it's challenging to navigate the system and to understand, especially
Mhm.
interprovincially, the variations in guidelines and protocols. So we're here to answer any questions and to try to connect people with the resources that they may
Mhm.
need to help direct that process for them.
And honestly, with any type of health problem, the hardest thing is knowing how to navigate the healthcare system to either
Mm-hmm.
get your questions answered or the care that you need.
Mm-hmm.
And regardless of where you live,
Yeah,
it's a difficult skill to
yeah.
obtain if you don't work in healthcare.
Yeah, and a large part of, I think, when you're dealing with rare disorders,
Mhm.
advocacy is
Yeah.
challenging to know where the right lines are and how to handle
Mhm.
that. So we're really happy to
Yeah.
offer webinars like this and access to specialists like you that most of the
Mhm.
participants may not be able to access regularly. And we
Mhm.
encourage individuals to contact us if we can help you find out any more information. We're happy to do that. So thank you so much for joining us this evening, and to everyone who
You're
has joined us
welcome.
this evening. It's through events like this that we really hope to empower families and patients and the community and healthcare professionals with the knowledge and resources needed to better understand and manage genetic aortic disorders. So we'd also like to acknowledge the generous support of the Temerity Foundation, who've sponsored events like this, whose funding allows us to continue advancing this education and the research and patient advocacy, in this field. So we encourage everyone to stay connected with GATA. And if you, again, have any questions, please do not hesitate to reach out to us. And thank you so much, Andrea, for joining us this evening. We really, really appreciate the time you
My
spent.
pleasure. Yeah.
Okay, well, thank you so
Good
much.
night,
Good
everyone.
night, everybody.